in the prognosis of patients who are given crystalloid or colloid solution during the perioperative period of major surgery. So the treatment with HERS is not recommended for elder patients with impaired renal function. And the intravascular volume expansion with HERS is not recommended in patients with sepsis or septic shock. In patients with preoperative hypoproteinemia, albumin can be used for fluid to maintain serum albumin level above 30. As we all know, the traditional fluid replacement volume calculation is composed of the following parts, and the target-oriented infusion on the premise of eras obtainance. Crystalloid solution was supplemented according to physiological requirement, and with blood transfusion, the colloid fluid was replenished according to the amount of bleeding 1:1. So in the case of blood transfusion, if necessary, keep hemoglobin more than 100, and blood loss minus blood transfusion is equal to the amount of colloid to be given. So for the intraoperative blood transfusion management, and the blood transfusion purpose is to improve the oxygen supply, not to make the hemoglobin reach to a certain target level. Whether hemoglobin level can maintain the balance of oxygen supply and demand depends on 3 factors. The first is arterial oxygen saturation. The second is cardiac output, and the oxygen consumption. The plasma should not be transfused until there is no active bleeding or definite laboratory evidence of a coagulation disorder. Also, the red blood cell to the fresh fluid plasma transfusion is 2:1. And the fibrinogen and the prothrombin complex infusion enhance the coagulation. For patients hemoglobin more than 100, no need transfuse red blood cell suspension. And for patients hemoglobin between 70 to 100, erythrocyte suspension should be, when we use the erythrocyte suspension, it should according to the patient's cardiopulmonary compensatory capacity, body metabolism, and oxygen consumption, and whether there is progress bleeding. And for patients hemoglobin less than 70, the transfusion of the red blood cell suspension should be considered. So for the elderly patients, the hemoglobin between 70 to 100, the blood transfusion strategy should be individualized. As we all know, the blood transfusion also causes some complications, so we need to reduce the bleeding. There are so many methods, such as we use advanced technology during the surgery to reduce the surgical trauma, such as the robotic surgery, AI, and the intelligent medicine, which was published in Wuhan. And there are some other methods, such as the local use of hemostatic, the tonic, and the controlled hypertension, as well as shortening the operation time. And this article showed that the controlled hypertension, the application of controlled hypertension used in the joint replacement surgery. And as the prolongation of the surgery, the bleeding decreases, and it has statistically significant. Also, in our hospital, for elderly low-limb joint surgery we also use the cocktail therapy to inject the joint. The cocktail therapy includes the hemostatic agents, ropivacaine, hormone, and vasoconstrictors. It's like a cocktail, right? So for the perioperative anesthesia, it's also an important factors affecting the patient's recovery. The perioperative pain is extremely in lower joint surgery. Patients with severe pain up to 60%. And 30% of the patients with moderate pain, of which 95% of patients have anxiety. So the pain can inhibit the body's immunity, can increase the incidence of cardiovascular and cerebrovascular events, also can extend the length of stay, and also the acute pain can become the chronic postoperative pain. Also, we use the intravenous analgesics such as opioid and non-steroidal anti-inflammatory drugs, and they also have we are used different pain such as moderate to severe pain. We use opioid, and for the mild and moderate pain we use the NSAIDs, and we also have some adverse. Sometimes we use epidural anesthesia. We use a different anesthesia method such as the epidural anesthesia and the peripheral nerve block anesthesia. That's the Dr. May side that. And they also have their advantages and disadvantages. As we all know, the postoperative pain is caused by the surgery, but it's also caused by the tourniquet, because the tourniquet have many side effects on the patients, such as the cardiovascular and the nerve system and the muscle system also can cause the patient pain. And this article shows that without tourniquet, so without tourniquet, and the VAS decreased compared with other groups. So the meta-analysis also showed the similar result. And in our hospital, for the elderly low-limbed joint surgery, post-operative pain had also taken a lot of measures. So such as before, we use no tourniquet, and before the surgery, we use the saphenous nerve block. And during the surgery, we use the cocktail therapy. And the surgeons standardize the operation and improve the speed of the operation, as well as the other method to improve the post-operative analgesia. So we can see that perioperative complications and management. And the first one is bleeding. The blood supply of bone and tissue is rich, and the blood loss of closed femur fracture, and the total hip replacement, and the knee replacement. The bleeding in the different surgery all have a lot of blood loss, more than 1,000 milliliter. And the prevention and the treatment, the maintenance of the hemodynamic stability is the basis of the treatment. When the blood loss is more than 15% of the total blood volume, it's necessary to supplement blood volume, as well as the physiological parameters and the functional extracellular fluid. And the second complications is common, and the embolism. It can cause the hypoxemia, non-neurological symptoms of head tremor, and skin and muscle bleeding point. And the first one is fat embolism. As we all know, in the joint surgery, especially in the hip surgery, then the local injury and the rupture of fat in bone lead to the fat drops going to the venas, and with the blood circulation, the fat drops goes into the lung and the cerebral vessels. But the most important thing is that the fat drops can be decomposed by the lung glycoprotein fat into free fatty acid, and it has strong toxicity to alveolar type 2 cells, and it also causes the release of vasoactive substances to damage the lung tissue and the capillary. And the second one is cerebral fat embolism. And the fat particles can cause the pulmonary circulation and goes into the pulmonary circulation and then goes into the cerebral circulation and cause a symptomatic of the brain. Also, we know that the application of the bone cement can increase the pulmonary artery pressure, reopening of the foramen hole, and cause the cyst and goes into the systemic circulation. Some research shows that ultrasound to monitor the number of emboli in the middle meningeal artery after the application of bone cement in 20 cases of hip arthroplasty, and 8 patients were found to have emboli in the cerebral circulation. So for treatment, we should early detection, just Dr. Huang said that for early, and adequate oxygen supply, and the control of infusion volume, and the clinical signs and symptoms of fat embolism can be alleviated by the short-term application of large dose of corticosteroid after severe trauma. Also, the hyperbaric oxygen therapy is necessary. And the others, such as the deep vein thrombosis and the pulmonary embolism, are caused by each other. And we should shorten the operation time, increasing the blood supply of lower limbs, and using anticoagulants during the operation. Secondly, we should immediately respiratory support and spasmolysis, analgesia, improvement of cardiac function, increase of cardiac output, and application of heparin should be used to prevent enlargement of the embolus. For the bone cement complications, and the symptom is palpitation, hypoxemia, and pulmonary embolism. And the palpitation is caused by the direct vasodilation or the inhibition of myocardium. We should use a fluid infusion as well as the vasoactive drugs. And for the hypoxemia, the administration of oxygen, monitoring of pulse, oximetry, use of sedatives with caution, avoidance of hyperventilation or airway obstruction. Also, appropriate fluid management and the use of diuretic is also necessary. And for the pulmonary embolism, the respiratory and circulatory support, as well as the anti-dissolution and the interventional thromboectomy is necessary, because the high intramedullary pressure caused by the bone cement destroys the thin veins of the femoral medullary cavity. As we all know, the tourniquet problem, and the tourniquet can cause a lot of problems and affect the nerve system as well as the muscle system. Also, it can affect the anesthesia. So we should, maybe we can choose the tourniquet individually and use it individually. So we should pay more attention to elderly anesthesia and elderly health. Thank you for your attention.
Thank you, Changping, who give us excellent lecture. Next is discussion time. Please, Professor Tianlong Wang, introduce panel guesses, please. Tianlong, Professor Tianlong.
Okay. Thank you, three speakers, excellent presentations. But now, in our session, we have to choose the panel guest. But now I prefer to introduce the two panel guests. The first is Professor 顾晓平 but now he is director of the Department of Anesthesiology of the Nanjing Drum Tower Hospital, the affiliated hospital of the Nanjing University of Medical Schools. The second, the panel, the guest is Xiuli Wang, but she is the director and professor, Department of Anesthesiology, the third hospital, Hebei Medical University. But now I invited the first guest, panel the guest, the Professor Xiaoping Gu, gave the first comments about the three speakers, the presentations, please. Professor Gu, you need to open your sound.
Open Michael.
Yeah.
Okay.
Thanks for the speech of the three speakers. I think these three topics are very interesting to all of us, and I learned much from three speakers. I think because it is discussion sessions. So firstly, I should ask some questions to three speakers. First, I should ask, Professor May, is Professor May here? No.
Professor May have the meeting. But,
okay, no problem. Yeah. Then I will just begin from Professor Zhao. I know that perioperative mutational brain monitoring is very important to the older patients. I know in your hospitals just a few years before you have used this one. How do you feel this kind of monitor changed the patient's endpoint? How do you feel about when you use this kind of monitor? Which kind of changes for these old patients?
Please allow me to try to answer this question and thank Professor Gu. It's a very good question because under the director of Dr. Wang, Professor Wang, there's a trend in our department. Most of our doctors will and very eager to use a multimodal monitor for the geriatric patient. And during operation, we not only monitor this, but also such as the PSI, DSA, these parameters. And during the operation, under the monitor of these parameters, we can adjust the dose of the anesthetics in very correct range, and reduce the chance of deep anesthetic or weak during the operation. So nearly 100% of the elder patients after the operation in the operating room, we will wake them up in very short time and take out the intubation very quickly. So they do not have the need to go to the ICU and for the ventilation for a long time. So we think under this management, we will provide the ERAS for the elderly patients. Yes.
Thank you.
I had actually from the lectures of Professor Wang Tianlong, I had learned that in your hospitals you would use mute monitors and actually get the patient back to the surgery room is very quickly and no need of ICU. So you would have more support of the hospital to give much more monitors to do these older patients. And we know that actually in your hospitals, the older patients is in a high percent, yes, about 50, more than 50.
More than
just last year's the 2021 in our hospital, more than 51% is old. The patient accepts the surgery. But for the advanced aged patient, nearly 15%. In last year's, we nearly 3,000 the advanced aged years old the patient the age is more than 75 years old. The nearly 100% not to ICU following the surgeries. But you know we provide the elderly patients the recoveries after the surgery. Yes.
Thank you. I think the older patient increase is a popular thing to all the hospitals most of hospitals. In our hospitals, is 9% is about 30, but it is increased every year. And today we actually more than 80% of AICU, yes, ICU of anesthesiology. The 80% of the patient is older than 65 years old. So in our hospital, most older patients would go to anesthesia controlled ICU to have a stable recovery. Yes, thank you, Dr. Professor Zhao. And the next, thank you. Next question I would ask for Dr. Gu. Yes. You have because Dr. May is not here. Actually, I am very interested in the older patients, the anesthesia method to older patients. We know that the pain control is very important to the patient. So we would use, if possible, we would use regional anesthesia with combined with general anesthesia to these older patients. I want to know, in your hospital, you would use no block first or intubation first in these patients?
Excellent, thank you. Actually, we most elder patients are used general anesthesia, and sometimes we usually combine the general anesthesia and the no block, such as the for the hip joint surgery. We use the light no block as well as the optio no block, and such as the joint replacement. We use a nephro bone block, no block, and the femoral nerve block. So sometimes and the surgeons also use the optic anesthesia method, and the patients who have the joint replacement surgery usually can usually get out of the bed the next day. And I think the post-operative anesthesia for this kind of patient is better than before. But most patients, we can combine the nerve block with the general anesthesia. And I think, sorry. And I think actually the elder patients, the most important problem of the elder patients is the decline of the single or multi-organs function. And there is no accurate assessment of this fragile. So I think we can do use complex anesthesia method to reduce the anesthesia agents used in the general anesthesia, and it's more safer for the elderly patients, especially for the fragile for the patients with the fragile organs. And just like the Professor May side, and then the nerve block, and is widely used in the elderly patients and in different surgery. And also we can do more the monitoring indicators. So keep the patients more safer during the surgery. Thank you.
Thank you. And I want to know the patient. We most in our hospital we would usually would meant when the patient use nerve block, they will feel the pain after about 12 to 14 hours later. And sometimes we will use IV anesthesia to get the pain relief. But would you usually use a tube insertion to the nerve block as a continuous anesthesia method in your hospitals?
Thank you. And this method because this method is less thin in our hospital, and because there are just 2 to 4 anesthesiologists can use this method, and sometimes especially use elderly patients with large trauma and with lung pain surgery, when the patients after have the lung pain after the surgery, and we the 1 or 2 anesthesiologists can use this method for this kind of elder patients. And I think the normal nerve block, such as the femoral nerve block and the ecstatic nerve block, as well as the general anesthesia, enough for the elderly, for the joint replacement elderly patients, or the hip replacement the elderly patients. And also when we use the general anesthesia, I think the general principle of the anesthetic medication is to have little effect on the respiration and circulation, respiratory system and the circulation system. and at the same time to follow the principle of individualization. So also I think we also consider the patient's liver or kidney metabolic process. Thank you.
Thank you. I have no more questions. I should transfer my position to Professor Wang. Thank you.
Open mic, Dr. Professor Wang.
Professor Tianlong, open your mic.
Okay, sorry. Sorry. But now I invited the second, the panel guest, the Professor Xiuli Wang, give us some comments. Maybe you have some questions for the speakers. Professor Xiuli Wang.
Okay. Good afternoon, everyone. I'm so glad to have opportunity to participate in this meeting. Just now, 3 professors shared their experience in ultrasound-guided peripheral nerve block, perioperative multi-brain function monitoring, and anesthesia management for elderly patients in bone and joint surgery. I believe the work are very helpful. With the increasing the aging population, the number of the old people undergoing surgery is increasing. They are more likely to have concomitant disease like involving heart, brain, kidney, and other important organs, especially the incidence of post-operative connective dysfunction is significantly increased. Professor Jolly's presentation of monitoring perioperative multimodal brain function provided us the good enlightenment to protect the brain from POCD. Today, ultrasound-guided nerve block are widely used in elderly patients who underwent bone and joint surgery. Female nerve block, like facial block, and pericapsular nerve group block, and other nerve block technique significantly reduce the use of opioid analgesia and post-operative complication, by which to improve the ERAS. Professor Maybe introduced the advantage of the ultrasound-guided regional block. Thereby speaks us the improvement on nerve block. Professor Gu introduced the external of anesthesia management in bone and joint surgery, especially in perioperative elderly patients. We thank the 3 professors who gave us the wonderful presentation. So I have a question for Professor Jolie. And you just, in your presentation, you just mentioned the pre-operative SEF may indicate the risk of POD. And would you mind can more expression for this question?
Thank Professor Wang. It's a very good question. Because of time limit, I didn't introduce more just now. This is a study of the students of Professor Wang. We select some patients and check the pre-operation SEF. And we found pre-operative, there's some difference of the SEF between the groups. The groups were divided after the operation according to POD or non-POD. So we have some suggestion maybe for the vulnerable patient, before the operation, perhaps we have according to some monitor or some examination, such as SEF, maybe RSF, MRI, and others examination, we could find some weak brain. And for these weak brains, perhaps we need more monitor during the operation and prevent the bad outcomes of the weak brain and develop the good outcomes. Maybe this our the meaning of our study.
Okay, thank you. Thank you, Professor Zhao, and you give a good answer. And I have a question for the Professor Gu. And in your presentation, you mentioned ACEI medicine and not to stop before operation. Why? Can you give me more explanation?
Okay, thank you, Dr. Wang. And as we all know, the elder patients also have the fragile kidney sometimes, and also have some morbidity diseases such as hypertension and the cardiovascular diseases, and also the other diseases. And they usually use many agents, such as the anti-hypertension drugs and the anti-asthmatic cardiomyopathy drugs. And when they use the ACEI medicine, and the patients, all the function of the organs, and especially the cardiac function and the kidney function are in a balance, and are in a balance, balanced. And if we stop the medicine immediately, and when we use the anesthesia, and maybe there are some other complications, especially the cardiovascular complications, maybe immediately appeared during the surgery, because the anesthesia after the anesthesia, so all the organs function are in a new balanced, and and the receptor which the ACEI effect in which the ACEI drugs plays on are usually immediately affected, and such as and the hemodynamic was affected by easily affected by the anesthesia. So to keep the patient's functions, organ functions balanced, and we should we suggest that the patients should use the ACEI and the ACEI drugs and such and other drugs, especially used for the hypertension and related with the cardiovascular diseases. Thank you.
Okay, thank you your answer. And in my hospital, we usually we recommended the surgeon not to stop the ACEI medicine. We recommended the surgeon to stop the ACEI medicine and change into the calcium inhibitor. I don't know, is okay, Professor Kenlong?
You give me a question. But in our hospital, you know, but in previous guideline to suspend the medication of the ACE and ARB to prevent the intraoperative monitor the hypotension. But now, if you suspend the medication with the ACE ARB, maybe the before the operation, the patient is experiencing the hypertension, but maybe the result in some of the complications. But now in our hospital, we didn't tell the surgeon to necessarily to suspend the medication with the ARB and ACEI. But when we make the pre-operative visitor, but if the patient have some medication, the histories of the ACE and ARBs, but maybe the patient have hypotension during the operation, but for this kind of the patient, but before begins the general anesthesia induction, we can initiate the infusion of the vasoconstrictors drugs such as the norepinephrine. Maybe the norepinephrine infusion rate, maybe the higher. In our hospital, maybe we recommend to increase the norepinephrine infusion rate to maybe the 0.1 microgram per kilogram per minute to prevent the ACE and the ARB related hypertension. These are our opinions to prevent the pre-operative hypertension because of the suspend of the ACE and the ARB. But now we can focus on how to prevent the hypertension during the intraoperative period. You can use the vasoconstricting drugs to prevent the hypertension. But first recommended in our department, first the norepinephrine, maybe, and then others. But for this, for the situation of ARB and ACE, the medications, the patients, I recommend the first line drugs is the norepinephrine. Has effective prevent intraoperative hypertension. This is my comments. Is your comments in your department not to stop the medication with ACE ARB in your department? Who do you want?
Okay.
Okay.
Yeah. Yes, in our hospital.
Maybe the Professor Zhao give your comments, your opinion.
And just like Professor Brown said, in our hospital, we use directly alpha receptor agonist to prevent the hypotension. So during the operation, hypotension rate is very, very low. Yeah.
Yes.
Mm-hmm.
I have common sense.
Yeah.
Thank you.
Okay, I think the medication should be individualized, and such as the fluid management and the blood transfusion. Because such as the guidelines show that the what I said in this speech also show that the crystalloid is the first choice for the patients. But sometimes a lot of colloidal solution can also save lives, because I met a patient which have the patient in the grassroots hospital, and the hospital have not enough blood supply, and it can use the colloid to supplement the blood volume. And the elder patient, this is also an elderly patient, and she has massive blood loss, and she was transferred from that hospital to our hospital. And I think if we don't use so many colloid, maybe the patient will die. So I think the medication, the fluid management and others should be individualized. Although the guidelines recommend the crystalloid is the first choice. Thank you.
Thank you, the professor's good answer. But I have a question for you. But in your slide, you mentioned to use the epidural anesthesia related the hypotension to provide a non-tourniquet to reduce the intraoperative the bleeding amount during the total knees arthroplasties. But for the direct anesthesia, but the first the benefit for patients, but epidural the anesthesia related hypertension, do not use the tourniquet. You can reduce the bleeding the amount during the TKAs. But another problem is maybe the hypertension will result in the organs dysfunctions. How do you think the problems?
Thank you, Dr.
My question is clear. Okay.
Okay. Thank you, Professor Wang. And actually, we don't use a tourniquet, especially in the joint replacement surgery, and because the surgeons in our hospital think the tourniquet have a lot of side effects for the patient's recovery. They ask the patients to get out of the bed the next day. Sometimes they will use the tourniquet, and they think the tourniquet can cause the muscle pain and cause the some hypoxia and cause they can decrease the intracellular creatinine levels. Also, they can because sometimes they think they can lead to the systemic effects after the tourniquet opening, and especially affects the patient's circulation, and also they can cause a transient decrease in intravenous oxygen tone, and the acid metabolism can be accumulated during the tourniquet use. So, and we think I think during the tourniquet and all the side effects, especially on the muscle, especially the side effects on the muscle, can affect the patient's activity, especially the next day's activity on the joint recovery. So they don't use a tourniquet, and they usually use the medications to control the hypertension, always below 20% below the normal pressure of the patient. And also there are some researchers show that it did have effect on the blood leading, but it may prolong the patient's hospital stay, and also it can decrease the patient's VAS scores. And according this, some patients will don't use a tourniquet, but for the cardiovascular diseases patients, they couldn't control the pressure by freedom. So sometimes they use the tourniquet for this kind of patients, especially the patients with the cardiovascular diseases, and also the patients elderly than 80 years, and other patients. Thank you, Professor Wang.
Yes, thank you for the answers. But as you speak, no tourniquet and hypotension technique, you need strictly to control the indications. But your topic is the joint and the bones, the surgeries in geriatric anesthesia. In this kind of the patient have maybe the more coexistent disease, such as you mentioned the cardiovascular disease, maybe have the fragile the brain functions, maybe the fragile the renal functions, maybe the less bleeding, maybe the most organs hypoperfusion related complications. We need to make the balance to prevent the complications. This is my key point. Okay.
Okay. Thank you, Professor.
Okay. But because of the time limitation, but I briefly make some summary. But today's our session, we have the three speakers. The first speakers is Professor Mei Wei, introduces the ultrasound, the regional anesthesia perspectives. He reviews the ultrasound histories and introduce their teams, the clinical research on the ultrasound, the guided regional anesthesias. From his lectures, indicate in the future, so we needed to explore the most the ultrasound, the regional anesthesia approach, and maybe we need to combine the most the ultrasound, the regional techniques to optimize the intraoperative the analgesia and maybe the anti-stress, the effectiveness. The second speaker is Professor Zhao Li. He introduces the much models, the brain functions under general anesthesia and algorithm management. But you know in past maybe the 10 and 20 years, we deeply focus on the sedation monitoring during the general anesthesia. But the noxious, maybe the analgesia death is the evidence in our clinical practice. But in fact, we know in geriatric patients, but there's a lot of cerebral complications following the surgeries. But now we need to monitor the sedations and the noxious levels and the cerebral situations to provide the deep sedation and inadequate analgesia and the cerebral hypotensions, hypoperfusions related complications to prevent the post-operative delirium and the QCD and even the post-operative stroke. This is very important. He introduced the overseas evidence and our team does some clinical research about the multimodal brains monitoring and algorithms management. But in the future, maybe we need some more evidence to prevent provide the precise cerebral protection strategies. But the third also speakers from the Changping he focused on the joint and the bones surgeries for patients anesthesia management, but focused on the monitoring for generalized patients, such as the ECG and the blood pressure, and especially the functionals, the monitoring and the beats and the body temperature and others monitoring. And others and include the fluid management and the patient blood management and the post-operative analgesia techniques. From the HERS presentation, but for the bone and joint the surgery anesthesia very challenges. But for this kind of patient, there is more common the coexisting disease. But during this kind of patient anesthesia, we need to balance the service, the benefits, and anesthesia related complications. We need to make the balance to let the patient have the most benefit from surgery and the anesthesia. Not only the focus on the surgeon's request, like the patient's post-operative complications, we need to make the balance between the two aspects. This is my comments for three speakers. But now, and thanks the two panels guests, the professors Xu Li Wang and Professor Xiaoping Gu. But thanks the moderator, the Professor Ma Hong. But thank you all. But now I'll at the end of our session, right? The second session will be continuous. I also thank you all and invite Richard to continue the next session. Thank you, everyone. Thank you.
Thank you, Professor Wang and Professor Ma for moderating this session. It is a session that we covered a lot of different topics. Last but not least, we will start our fourth panel, and the fourth panel will include topics on emergent airway management, intraoperative ultrasounds on anesthesia, and ski doctors at 2020 Winter Olympics. Professor Mi Weidong and Professor Yu Weifeng are our moderators. allow me to introduce both of them. Professor Mi-Wei Dong is the director of the Department of Anesthesiology of the First Medical Center of PLA General Hospital. He is Major General in Professional Technology, member of the Standing Committee of Chinese Medical Doctor Association. He is a Vice President of Chinese Society of Anesthesiology and President of Chinese Military Society of Anesthesiology and Resuscitation. Professor Yu Weifeng is a chairman of the Department of Anesthesiology at Renji Yiyuan at Shanghai Jiao Tong University School of Medicine. He is a vice president of the CSA. He is a chief editor of Anesthesia Vision, vice chief editor in Chinese Journal Anesthesiology and Journal of Clinical Anesthesiology. Professor Mi, Professor Yu, the floor is yours.
Okay. Thank you, Dr. Richard. Thank you for introduction to us. It's my pleasure to chair this Hello.
Hello. Yeah, I can hear you.
Phone. You heard me?
Yeah. Can you hear us?
Okay. So, okay, let's start. It's my pleasure to chair this session with Dr. Yu. Can you hear me?
Yes.
Yeah. Dr. Yu will introduce the first speaker, please. Weifeng, it's your time.
Good afternoon, everyone online. I'm Yu Weifeng from Renji Hospital, Shanghai Jiao Tong University School of Medicine. It's my great pleasure to be invited to attend the Beyond Expo Anesthesia and Life Science sub-conference. It's my great honor to host the following academic activities with Professor Mi-Wei Dong. First of all, I would like to introduce Professor Mi-Wei Dong. He is Vice Chairman of CSA from PLA General Hospital. Three speakers will speak on emergency airway management, intraoperative ultrasound, and health care for the Winter Olympics. The two reviewers are Professor Zuo Mingzhang from Beijing Hospital and Professor Dai Luping from the Second Xiangya Hospital. All right, let's welcome our first speaker, Professor Gong Yahong from Peking Union Medical Ecology Hospital.
Pleasure.
The topic of her speech is emergency airway management for patients with anaplastic thyroid cancer. Please, Gong Yahong, Professor.
Thank you. Thank you very much. Thank you very much. Thank you, Professor Yu, for the introduction. And thank you for having me here as a speaker. I'm greatly honored. And good afternoon, ladies and gentlemen. I'm Gong Yahong from Peking Union Medical College Hospital. And I would like to talk about the airway management of critical central airway obstruction caused by anaphylactic thyroid cancer. Firstly, I would like to say some words of our hospital. PUMCH has a long history, and we have just celebrated the 100th birthday last year. And PUMCH has ranked #1 in Fudan Hospital ranking for 12 years. And we are the National Referral Center for Critical and Rare Diseases. And anaplastic thyroid cancer actually is a rare disease, but not rarely seen in our hospital. It is an aggressive disease, which is a significant contributor to the morbidity and mortality burden of all thyroid cancers. The disease-specific mortality of ATC is exceedingly high, often cited as 100%. And the median survival after diagnosis is between 3 to 7 months. Because of the rapidly expanding of the tumor, local invasion is very common. So the patients may present with obvious dyspnea, stridor, and dysphagia on admission. And actually, the rapid airway compromise is the main cause of death in ATC patients. The airway issues of ATC patients may be related to large mass in the central compartment, which may cause extensive tracheal compression. And in some cases, vocal cord may be involved and the vocal cord paralysis is present. In others, direct infiltration of the tumor into the tracheal lumen is also quite common, which may cause different degrees of intrinsic airway obstruction. And in these cases, the airway may be considerably compromised, or the patient may bleed in the tracheal lumen, leading to acute airway distress and rapid fatality. In more than half of the ATC patients, dyspnea and stridor occur at the initial complaints. These manifestations are more prominent during exercise when the lumen is reduced to 8 milliliters. But the symptom may progress to dyspnea at rest when the lumen is reduced to 5 milliliters. So when we are asked to intubate the patients with obvious airway symptoms, it is critical to understand the qualitative and the quantitatives of the obstruction. We want to make sure whether the obstruction is caused by the extrinsic compression or the intrinsic infiltration, whether the obstruction is fixed or dynamic. So we also want to quantify the symptoms of functional class and evaluate the severity and extent of the airway narrowing. Therefore, we usually recommend that all ATC patients undergo cross-sectional imaging to adequately evaluate the airway at the time of diagnosis. High-resolution cross-sectional imaging is critical for surgical planning, and the bronchoscopy is useful to determine the extent of the disease, evaluate the tracheal lumen and the luminal obstruction, and to assess the resectability of the tumor. In cases of symptomatic malignant airway compromise, the intervention should be rapid and effective with low associated morbidity and mortality. If the intervention is palliative, it should require limited follow-up care in an effort to maximize the patient's quality of life. So, according to these principles, local regional resection is often indicated in most patients, but the procedure is very complicated and the airway must be secured before the surgery. As anesthesiologists, we are often asked to secure the airway in the emergency room. But when confronted with ATC patients with central obstruction of airway, we may find that the airway management can be very challenging because difficult laryngoscopy, difficult face mask ventilation, and difficult surgical airway can be concurrently predicted in these patients. So rapid sequence induction is usually not recommended, and the retaining of spontaneous breathing is very important. It is in most anticipated difficult airways, if both difficult intubation and difficult ventilation are estimated, awake tracheostomy is often recommended. But in ATC patients, tracheostomy should be approached with more hesitation and reservation. For this, there are many reasons. Firstly, tracheostomy procedures can be extremely difficult.
because in these patients, there may be extensive tumor in front of the trachea, making it practically impossible to identify the trachea and the tracheal lumen. Secondly, the extension of the neck and the horizontal position of the patients may precipitate acute airway catastrophe. So the patient may not tolerate the awake tracheostomy. Therefore, emergency room or crash tracheostomy may turn out to be a major disaster. Thirdly, it is also difficult to secure a tracheostomy tube in such patients because of the considerable distance between the skin and the trachea when it was filled with tumor. So furthermore, the tumor can erode the tracheostomy and fungate around the tracheostomy, which may result in dislodgement of the tube and decrease the patient's quality of life. Therefore, tracheostomy may not be a good way to solve the airway problems. So keeping in mind, emergent tracheostomy at the bedside should be avoided. If a tracheostomy procedure is requisite, in as much as possible, it should be planned in advance and performed in operating room with skilled surgical team and necessary resources. Involvement of a fiber optic intubation can guide the identification of trachea intraoperatively. And we have to consider whether we should do cricothyrotomy or tracheostomy in emergent cases, because cricothyrotomy may be an easier surgical procedure and it is less likely to dislodge second to Barkov fluids. Here, I would like to share one case. A 59-year-old male who was admitted to the emergency room at midnight with progressing dyspnea at rest for 20 days. He's in a forced semi-sitting position, and the 3 depression sign was obvious during the respiration. He was on 10 liter per minute oxygen nasal catheter, and SpO2 was only 91%, but vital signs was relatively stable. We can see this patient breathing very hard, and the CT cross-sectional imaging and the 3-dimensional reconstruction showed that tumor had tumor had infiltrated into the trachea, and the tracheal lumen had reduced to 3 to 4 millimeters. Because of the obstruction located in the middle trachea and the size of the tumor in front of the neck is not that big, tracheostomy seemed visible. So tracheostomy was carried out in OR with extensive monitoring, including ECG, SpO2, and also IBP, invasive blood pressure. But during the procedure, the bleeding was massive and the tissue was obscured because of the tumor. So the trachea was severed after the anterior wall of the trachea was accidentally damaged. Anesthesiologist, which is me, I intubated a tube, but the tip of the tube emerged from the poorly dissected tumor. So the patient developed severe hypoxia and circulatory collapse. Finally, I suggested ENT surgeon to perform needle aspiration of air among the tumor. Finally, they find the trachea and put a size 5 tube into the trachea via Seidingler technique. It's a very tough case. So remember, tracheostomy can be very risky in these cases. As for endotracheal intubation, it can be achieved with direct laryngoscopy, video laryngoscopy, and flexible bronchoscopy, and the rigid laryngoscopy. Different devices have different advantages, but the appropriate device should be selected according to the specific situation of the patient. For this one, a male patient, 52 years old, who was presented to the OR to resect a huge ATC. He presented with exertional dyspnea, and the CT scan showed external compression of the trachea. The narrowed tracheal lumen was 6 to 8 millimeters, and the stenosis extended into the thoracic cavity, 3 to 4 centimeters above the carina. But laryngoscopy was predicted with no difficulty because the mouth opening, Lambert score, and the neck flexation was relatively normal for this patient. You can see the patient, the picture of the patient. So for this case, I think laryngoscopy is with no difficulty. So the airway was sufficiently topicalized, and the patient was moderately sedated. Spontaneous was retained, and the successful intubation was achieved by video laryngoscopy. And another case is reported in a case report. A 38-year-old female with ATC, and the tumor has infiltrated in the upper trachea, occupying 80% of the lumen, whose laryngoscopy also predicted with little difficult. So the author reported that successful airway management was achieved using awake video laryngoscopy, just as our case. So although fiber optic intubation is a well-established and versatile tool for airway management in patients with known or suspected difficult airways, it has high technical requirements, and the railroading of ETT can fail even after a successful bronchoscopy. So as for some patients, video laryngoscopes are maybe a good alternative because they are more familiar to most anesthesiologists. They can offer better laryngeal exposure and permits a significantly higher percentage of visualized, controlled endotracheal intubation. So I think video laryngoscope is a good alternative to bronchoscopy in some patients. But in patients with severe airway distress, and especially in those that we are not sure whether intubation can be achieved with video laryngoscopy, video laryngoscopy should be approached with caution. It's not recommended because attempted laryngoscope may cause damage to peripharyngeal tissues. So the patient's symptom may worsen after a failed intubation attempt. So compared to the laryngoscopy, bronchoscopy can be reversible with little sequela. For this case, a 69-year-old female presented to the ER with dyspnea for 1 month and aggravated for 1 week. She had severe dyspnea with SpO2 of 70%, and she was delirious. She must be on mechanical ventilation, and the CT scan was also impossible. So for this case, I think video laryngoscopy is contraindicated because we are not sure whether we can intubate the patient with video laryngoscopy. We know little about the conditions of the trachea. So for this patient, we sufficiently topicalized the airway, used nebulization with lidocaine and the lidocaine spray, and we prepared the nostrils, and we also spray as you go when we are doing the bronchoscopy. So we topicalized the patient sufficiently, and no sedatives was administered. The first bronchoscopy attempt showed that bilateral vocal cords were nearly closed, and it was difficult to pass the bronchoscope. At that time, I just think that maybe it was because the local anesthesia is not enough. The patient may suffer from laryngospasm caused by insufficient surface anesthesia. So I gave another additional local anesthesia to the oropharynx. But the second attempt revealed that bilateral vocal cords were still fixed during forced inspiration. And I think maybe it's not it's not the laryngospasm. So finally, I squeezed the bronchoscope through the vocal cord with moderate force, and successfully the bronchoscope entered the trachea, and then an ETT tube of size 6 was railroaded. And after a successful intubation, the patient went to CT scan, and the CT scan showed that the tumor had invaded into the trachea, and the cricoarytenoid joint and the thyroid cartilage were both damaged. That's why the vocal cords were fixed. You can see here the cartilage has been damaged, widely damaged. And nowadays, interventional pulmonology has evolved rapidly in recent years, and the therapeutic bronchoscopic options now available to practitioners continue to expand. Some ablative techniques such as laser, electrical cautery, microdebrider, and cryotherapy can be used in the debuckling of the obstructing tumors. But small volumes of blood in the airway can result in significant oxygenation problems. So, though there are many techniques that can be used to debulk the tumor into the trachea, I think we should approach these techniques more with caution. A plan for hemostasis is essential during debuckling, and I think only experienced center and experienced expert should take care of these kind of cases. It should not be undertaken in the hospitals who have just begun this kind of techniques. I think it's contraindicated. So rigid bronchoscopy is an alternative, but it must be handled by experienced hands. And also, in some cases, extensive local spread with intrathoracic tumor extension can lead to a long segment involvement of the trachea, and even in some cases, proximal major bronchus can be involved. For these patients, therapeutic rigid bronchoscopy with tracheal stent insertion is an alternative and efficacious treatment modality. But also, I think it's require much technique and should not be undertaken in the centers or in the hospitals who have just begun these techniques. Because stents can increase the airway rigidity and resist extrinsic pressure. It can compress the airway wall and serve to recreate the airway lumen. But this modality, is usually a palliative treatment. It can only recreate the dependency of the airway. So if the tumor is too large and cannot be resected totally, this palliative care is not enough for the patients. So palliative care specialists is needed to focus on multiple domains. So we have to involve them to start comprehensive discussions with the patients. We have to discuss about the mortality, the morbidity of this disease, and we have to solve the emotional, social, intellectual, and spiritual needs of the patients and the family. And I think because in this kind of disease in ATC patients, the overall mortality is exceedingly high, and in some urgent cases, maybe even we have done a lot, we have tried all our best, the patient may, turn out to be ended bad. So I think the palliative care is very important in these cases, and the palliative care should not be overlooked. We can't cure the patient, so we have to care and we have to comfort the patient. And that's all. Thank you.
Thank you, Professor Gong Yahong, for her wonderful speech. Let's welcome Professor Zuo Mingzhang and Dai Luping for the comments.
Thank you, Professor Yu. It's very glad to see you. And thank you, Professor Gong, for your excellent presentation. You gave us 4 cases with a cerebral cancer. Trachea is depressed. And you deal this emergency difficult area very, very well. My question is where do you deal with such difficult area? In the emergency room or in operation theater, before surgery, before induction, before surgery? This is question 1. Question 2 is, if it's, we know this patient, maybe we can say it's easy to laryngoscope, but it's very difficult to put the tube in through the trachea and pass the stenosis area of the trachea. And what do you think ECMO can play some prepared in such a situation? That's my question.
Thank you. Thank you very much, Professor Zuo. You have raised a very good question. And usually in our hospital, I've met ATC patients for several times. And usually when the patient was in the ER, I was invited to intubate this patient in the OR, but in the ER. But I think intubation of this kind of patients can be very difficult and can be very risky. So if we decided to try the intubation and the tracheostomy, usually we would like to transfer the patient to the OR, because in OR we have much devices and we have more hands to help you, and we are more familiar with the circumstances. So I think for this patient if we want to manage this kind of patients, we have to transfer the patient into the OR before we manage the airway. That's the answer for the first question. And speaking of ECMO, actually it's a tough decision because the prognosis of this patient with ATC is universally poor. The prognosis is universally poor because the mortality is cited 100%. So despite all the improvement in treatment, most patients with ATC patients have a median survival of 3 to 7 months. And for the patients in advanced stage of the disease, as you have mentioned, maybe the trachea, the luminal diameter of the lumen is very narrowed and it cannot be intubated. So as for this patient, I think the survival rate may be even less than it can be counted in days. So for this patient, I think total resection of tumor is impossible. So, but for ECMO, it has expensive costs and a relatively high incidence of morbidity, including bleeding. And also, it is very difficult to establish ECMO in a severe hypoxic and agitated patients. So, although ECMO may provide short-term correction of hypoxemia, but it may hinder surgical treatment, and it carries a high risk of failure when during the establishment. And even if the ECMO is established, it is less likely to bring more benefit to these patients. Therefore, we believe that ECMO should be approached with reservation in these patients. Instead, in these circumstances, if the patient is really that severe hypoxic, is really so advanced in the disease stage, we encourage to initiate comprehensive discussions with the patients and the family on terminal care if intubation and tracheostomy is nearly impossible. And ideally, as I've mentioned, we should involve the palliative experts in this conservation so that the emotional, social, intellectual, and the spiritual needs of the patients and the family can be met. I think ECMO, the benefit of the ECMO is not that much in these kind of patients. That's my opinion. Thank you.
In some situation, Professor, in some situation, it's really difficult. Even you consider vehicle code, you cannot pass even small trach tube inside the trachea and pass over to the stenosis of the trachea. But at that time, the hypoxemia saturation is down. So it's really emergent situation. So at that situation, what do we do to save the patient life? What do you think?
You have raised the most difficult questions for me. I think it's not a decision for me alone. I think it's a big question for both the doctors and the families. Maybe at that time the patient is unconscious, so I think it's very difficult. Actually, we did have put one patient with with severe hypoxemia on ECMO, and it turned out that ECMO runs very well for on the first day. It can solve the problem of hypoxemia, but later when the patient underwent the procedure, the surgical dissection of the tumor, the bleeding is very massive. So the patient actually didn't end well. The patient was died 2 days after surgical debuckling. So, I think as for if the patient is really hypoxic, at that moment, what we can do is to provide comfort, to start our palliative care. I think it's really difficult. Yes, right. Sometimes maybe medicine has its limitation. That is one of the limitations.
And in my opinion, ECMO should be at that time. ECMO should be prepared in the operation theater for such a very difficult situation. In a other hand, surgeon should be standby to work together to keep the patient safety. Thank you, yes. Professor Gong.
Yes, I'm completely with you there. If we try to manage this kind of airway, we would communicate with the family, multidisciplinary, the surgeons and the ICU doctors, intensivists, and anesthesiologists. We would, form a multidisciplinary team and communicate with the patients, and we would discuss about the tracheal intubation, the tracheostomy, and ECMO as well. But usually we would tell them the the shortcomings of ECMO, and maybe it will took them a lot of money, and all the money will go to Vena, didn't come out well. So we would like to talk with them all the details, and of course the decision is up to the family and the patient. But we will fulfill all these steps. Yes, right. I'm completely with you there. Yes, and the surgeons will get prepared, of course. But usually in these cases, if intubation failed, tracheostomy is very difficult.
Okay, thank you.
Dr. Gong has talked a very wonderful presentation. So my question is that after you successfully intubate the tube, do you have any comments about the extubation for these patients? Because not only intubation is the most difficult, it's also important for us to extubate. Can you give us some comments?
Thank you, Professor Dai. You have raised another good question. Yes, I think for anaphylactic thyroid cancer patients, not only the intubation procedure is risky, but also the extubation procedure is quite risky. Why? Because for the patients, when the airway is secured, usually the surgical debuckling or surgical resection is followed by. So after the operation, there will be a lot of risky to extubate the patient. Firstly, the patient, as I've mentioned, local invasion into the trachea is very common in these kind of cases. So the tumor may invade the trachea. So during the surgical resection, part of the tracheal wall or tracheal ring may be resected. It's quite common. So the patients actually should be intubated for 24 to 48 hours under close observation. So usually after the operation, we would transfer the patient to the ICU for 1 or 2 days and keeping them intubated and ventilated. And the plans for re-intubation and other intervention should be discussed prior to extubation in case of decompensation, because after intubation, maybe a lot of things can happen, like massive bleeding or airway collapse. So we will make a plan for reintubation. So a well experienced surgical team and critical care staff and anesthesiologist usually are summoned to be available for extubation, even in the ICU. Yeah, in case the patient need further intervention. So actually, in our hospital, if the patient is to be extubated, anesthesiologist will be summoned to the ICU to stand by, and as well as the ENT surgeons, they are summoned to the ICU. And in some extremely high-risk patients, usually we would transfer the patient back to our OR to extubate the patient. And after 1 hour of observation, if the patient is stable, then the patient will be transferred back to ICU. As for this patient, we should pay a lot of attention to it. Yeah. Thank you.
Okay, thanks.
Thank you again for Professor Gong Liahong's excellent speech and
Dr. Yu, I have 2 questions to Dr. Gong.
Yeah.
Okay?
Yeah. Okay.
The first question is similar to Dr. Zuoming Zhang about ECMO use for this kind of patients. My question is, any experience in your department to use ECMO for this kind of patients? The first. Second is, how about the trachea malaria management in this kind of patients? Two questions, please.
Thank you, Professor Mi. Actually, as I've remembered, we have used ECMO in one patient with ATC thyroid and with ECMO, and we have used ECMO in one patient with another benign tumor in the trachea, as the first case I've introduced, I've talked about it earlier. The ECMO have induced severe, massive bleeding post-operatively. So the patient turned out to be, turned out dead. But for the second case, the patient actually was severely hypoxic. So we put ECMO on, and we resected the tumor, the benign tumor in the trachea, with the ECMO, and the patient was completely recovered. And I think, as for a near complete obstruction of the trachea, ECMO is a good device to provide the quick correction of the hypoxemia. Is a very good device and a very good technique, but we have to take into consideration the mortality of this disease and the ongoing procedures. We have to consider about that. So in ATC patients, I think ECMO is relatively contraindicated. That's my opinion. That's the answer for the first question. We do have done some cases with ECMO. And for the second question, you are concerned with the tracheomalacia, right?
Yeah.
Yeah. I think anaplastic thyroid cancer progresses very rapidly. And actually, the tumor can expand into a large size within 1 or 2 months. Therefore, when the patient comes into clinic, the course of the disease is usually not very long. It's not very long. And I think the incidence of tracheomalacia was quite low. I've just mentioned extubation of ATC patients carry other risks. Because usually if the tumor have infiltrated the tracheal wall, your part of the wall resection, tracheal wall will be resected. Yeah, that will cause maybe a tracheal rupture post-operatively, and in some patients tracheal rings, maybe 1 or 2 or even 3 tracheal rings may be resected. So in this kind of patients, if tracheostomy was not performed, we have to be very cautious. The patient have to be intubated for at least 2 days to let the wound to go as well, and then we can extubate it. Yeah, that's very risky. Yeah. Or you can just you can just establish tracheostomy, and that will be if a lot of rings has been removed, then the tracheostomy must be performed. Yeah. Thank you.
Thank you for your answer.
Any question? Thank you very much. Now please welcome Professor Mi Weidong to deliver the second speech academic report.
Okay, the second speaker is Dr. Du Yizhi. He is an attending anesthesiologist and associate professor at Inner Mongolia Medical University Hospital. She is a member of National Youth Committee of CSA and the National Youth Committee of Chinese Society of Pain. Dr. Yu is also a national committee member of ultrasound study group in CSA. Her topic is application of intraoperative ultrasounds on anesthesia of critically ill patients. Now, please, Dr. Du.
Okay, thanks for Professor Mee's introduction. And okay, I wanted to share my PPT, and it's cannot. How can I share this PPT? I just.
共享一下屏幕。
Yes, I did, but I cannot. I don't know why. Actually, can someone just help me? Can someone just help me? Because my PPT cannot share on the screen.
要不要退出来再进一下？
I'm sorry.
You can quit, exit and try to enter again.
Okay, yes. I know. Okay, can someone help me?
Can you exit the meeting and then back again to see?
Okay, I'm sorry about that. Why? It still cannot share. Why? I don't know why.
Dr. Yu.
Actually, yesterday we tried it. It's really success and smoothly, but I don't know why today is really.
Is there anybody sharing the PPT?
No.
Otherwise, you can. That is surprise.
Okay. It's okay now. I'm sorry about my poor computer technology. So, my name is Du Yi. I come from the anesthesia department of the affiliated hospital of Inner Mongolia Medical University. So, first of all, I would like to thank Professor Mee's introduction. And this is a great honor for me to be a speaker here. Actually, when I saw the schedule, the moderator is Professor Mee, I was a little bit nervous because Professor Mee Weidong is my doctoral mentor. And you know why? Speaking in front of your mentor make me feel like an exam. So I hope I can do good job today. So let's begin today's talk. Application of intraoperative ultrasound on anesthesia critical ill patients. Then clinical ultrasound screening evaluations are widely used perioperatively. During perioperative monitoring, we can use ultrasound from head to toes for many clinical situations. Wherever the ultrasound probe placed on any part of the body, it can give us a rapid assessment, early diagnosis, and timely intervention information. So, as an anesthesiologist, we should not only depend on our clinical experience, but also obtain certain clinical skills and techniques. So with the development and popularization of ultrasound technology, bedside or so-called point-of-care ultrasound has provided more and more clinical information about critical patients. So we often call the ultrasound is visual stethoscope. Then this is the picture current, application of ultrasound used in our departments. So perioperative ultrasound can be used to evaluate the circulatory system from the aspects of morphology and function. and it has the basic functions of positioning, qualitative, timing, and quantitative. So it can provide basis for, perioperative diagnosis and treatment decisions and improve the safety and effectiveness of anesthesia surgery. So now I would like to present 2 cases to demonstrate ultrasound screening used in acute, really sick patient or just like clinical assessment and rescue in our departments. So this is the first case, and the patient's general information is a male, 60 years old patient, and 170 centimeter high and weighted 85 kilogram, and presented to have laparoscopic cholecystectomy for cholecystitis and gallbladder polyps. And the patient past, medical history includes 10 years of hypertension and well controlled by taking nifedipine orally. And all the routine test results were in normal range. Nothing is special. And the preoperative ECG, echocardiography, and X-ray results were normal, and except for the left ventricular diastolic function was a little bit slightly decreased. This change is commonly seen in old and like hypertensive patients in our Euro work. And the patient in around 15:20 in the operating room, and we prepare every step for the patient. Then around 15:35, anesthesia induced, we use the normal medicine. And then around 15:50, surgical procedure just started. Then after 1 hour surgery, then the gas was off, closed the skin, and then the surgery has done. Then at this time, around 16:58, a sudden blood pressure drop and heart rate increasing attracted the attention of the anesthesiologist. So we just like normal treatment to treat this patient, give the patient rapid fluid infusion and repeatedly give them phenylephrine to treat the blood pressure low. But however, the treatment effect is really poor and the blood pressure is still difficult to maintain. And heart rate reached to 125 and blood pressure dropped to 70 over 40 millimeter mercury. And we just, because these patients, treatment effect is, if reaction is really abnormal. So we immediately help was called. And at the same time, we just asked the resident to put the airline in, and the CV catheter was placed. And HR was, heart rate was still rapid and blood pressure was still low. And, during this time, we give the epinephrine was given for several times. And at moment, fluid, infusion and vasopressor therapy could not improve hemodynamic status. And although dopamine and norepinephrine infusion are applied, and the blood pressure was still difficult to maintain, and echocardiography was performed. We can see this picture. PTE shows the short axis view of the patient's left ventricle. And we can see the left ventricular systolic function was okay. The interventricular septum did not move towards to the left and in middle, and indicating that the right ventricular function is also okay too. So it also showed that the capacity was critically low, and the ultrasound screening assessment quickly lead to somewhere bleeding. So we quickly checked this hepatorenal space, and then we just found that no bleeding was found by ultrasound. Actually, hepatorenal space is maybe more than 5 millimeter. It show that just like have some bleeding here. So this patient is not. And according to the results of ultrasound screening, the crystalloid and the colloid solution were infused through multiple channels. But the ultrasound showed that the volume was still seriously deficient, just like that. And hemoglobin began to decline, indicating that active bleeding inside and no obvious signs of bleeding were found at the hepatic portal. So where did the blood go? Then we asked the surgeon to re-exposure, abdomen to find bleeding sources. After getting into the abdominal cavity, no bleeding was found at the porta-hepatic cholecystectomy site, but a large amount of blood and blood clots were drawn from the pelvic cavity, so indicating that there were bleeding sites, but no bleeding sites were found at several trocar sites. After pulling out the trocar at the abdominal, cavity in the middle of the umbilical cord, then the bleeding site was found. There was a big vein at the location of the umbilical trocar site, and the vein tearing explains severe hypotension and tachycardia began at time when the umbilical trocar was pulled out and the skin was sutured after the operation. So after repairing the bleeding blood vessels and giving fluid infusion and blood transfusion treatment, the patient's blood pressure and heart rate were stable. After the operation, the patient was awake and extubated and then returned to the ward safety. But the patient were, followed up after obtained and an angiogram was performed. We can see the left, side. And this is the inferior vena cava angiography was normal person. You can see the inferior vena cava from down to up, it's really smoothly. And we can see our patient's right branch of inferior vena cava just has many branches in the pelvic cavity. It also explains why the patient has an unusual large blood vessel distribution at the belly button area. So especially for the red circle area. And for this kind of patient, I have the following summary about this patient. Even the hemoglobin was 9.1 in ABG, and patient was still in significant hemodynamic unstable, indicating that the elderly have a worse tolerance to ischemia and hypoxia. It tells us for elderly patients, we should pay close attention to the changes of the patient's vital signs and correct the abnormal state as soon as possible, as soon as quickly. Then the second one is, this patient's ultrasound has provided us with important cardiac function and volume status. The lesson learned, I did not involve pelvic ultrasound in my ultrasound screening, although cardiac ultrasound repeatedly indicates that there is an insufficient volume, but I still ignore that because there is no systematic learning about pelvic ultrasound. I did not find a large amount of blood accumulated in the pelvic cavity at the first time. So this lesson teaches us that it is necessary to master the whole technology of ultrasound, especially for the anesthesiologist. So a comprehensive ultrasound technology can significantly improve the anesthesia safety and quality and quickly detect abnormalities in the perioperative period. So the third one is my personal opinion. In my opinion, I think the ultrasound to anesthesiologists in the perioperative period is more qualitative structure identification than quantitative calculation. The qualitative diagnosis is particularly important at critical moments. So we need to quickly assess the abnormal status of patients through ultrasound and leave the quantitative and specific measurement to the ultrasound specialist. So when we're saving a patient is race against time, we only need to know meaningful abnormalities to guide us in early detection, early diagnosis, and right treatment. And the exact value can be given to ultrasound specialists because time is short. It is more important for anesthesiologists to find abnormalities. So this is just my own opinion. Okay. Then the last one is the successful rescue of this provide the importance of early code blue and teen cooperation. At the beginning of the rescue, our medical team from the director to the resident arrived at the scene at the first time, which is the key to our successful rescue. So when the ultrasound indicated that volume was insufficient, but there was no clear sign of bleeding, but the director decisively asked the surgeon to perform laparoscopy exploration. So then the patient can rescue really smoothly and rapidly. And then share the next case. The case is around, patient who is 29 years old male and height 170 centimeter, weight around, 72 kilogram. Was brought to the hospital because of a car accident to the left lower limb, open fracture. And patient has also had altered mental status for 5 hours. And his general health before accident was pretty normal. And we can see on exam, his heart rate around 136 BPM. The heart sounds were low and blunt with irregular rhythm. And blood pressure around 75 over 30 millimeter mercury. And the respiratory rate was 25 minutes per minute. And patient is confused. And CT scan showed multiple fractures, including left femoral, left tibial plateau, and left tibial fibular, and left patello. And then the head and the chest CT was normal. So the pre-operative diagnosis was multiple injury and hemorrhagic shock. And the patient's pre-operative, blood routine test showed that the hemoglobin just have, 4.3. It's really low, right? And this is the CT and X-ray results for the patient after arrived in the hospital. This shows comminuted fracture of the left femur and left tibia and left fibula. And then the anesthesia process is as follows. The patient in the operating room with a heart rate around 143 BPM and blood pressure around 66 over 40 millimeter mercury. We use the non-invasive, blood pressure monitoring methods, and patient under coma. And anesthesia induction, we use the etomidate, rocuronium, and sulfentanyl. It's really normal anesthesia induction methods, and then maintained by propofol and remifentanil. And this patient is really sick, so we monitor so many, methods by ART and CVP, HR, PETCO2, SpO2, BIS, urine volume and body temperature, arterial blood gases, and TEE. So after the patient was brought to the operating room, the blood gas showed that hemoglobin could not be measured. After the induction of anesthesia, he began multi-channel and rapid blood transfusion. However, he was always in low blood pressure and fast HR heart rate, and he was given intermittent phenylephrine, and at the same time, dopamine infusion for maintenance. And within half an hour after the induction, the heart rate was suddenly reduced to 30 times per minute twice, and the blood pressure was dropped, and he was given immediate treatment with epinephrine. Then, however, the blood pressure could not be maintained, and heart rate was actually fast in responded to epinephrine. And during this time, we have already given the patient 6.5 units of PRBC and 2,000 or so crystal and colloid solutions had been given. So the heart rate and blood pressure are shown in unstable, and the central venous pressure is getting higher and higher. To further evaluate the cardiac infarction and volume, we checked the TEE and found that the left heart had strong contraction, and also found that the volume was insufficient. But why has such a high CVP? We just confused with such doubts, and we continue to observe other sections of the heart. So as we can see in the apical four-chamber view and the right ventricular inflow-outflow tract view, we found that tricuspid regurgitation occurred, and at the same time, the centripetal activity of the pre-all of the right ventricles was significantly weakened, and there was right ventricular insufficiency. So, to a patient with bone fracture, and he has had fast heart rate, low blood pressure, and significant high CVP, we were highly suspicious of the existence of pulmonary embolism. So with this doubt, we continue to observe the section of the pulmonary artery and found no evidence of the existence of thrombus on the walls of the main pulmonary artery, left and right pulmonary arteries. We can see the picture. This is color Doppler just for show the pulmonary artery. So at the same time, we found that the pulmonary artery pressure was not high through Doppler blood flow spectrum. In addition, during this period, the blood oxygen was maintained at 100%, and the end expiratory carbon dioxide did not change, corresponded to pulmonary embolism. So therefore, pulmonary embolism was quickly ruled out, and considering that the occurrence of acute cardiac insufficiency may be mainly caused by the poor coronary perfusion caused by acute massive blood loss. Then we change the treatment approach. When we give the patient guaranteed preload, we use the multiple channel pressurized blood transfusion was continued under TEE monitoring, and give the patient protection of right ventricular function, use dopamine or norepinephrine to keep the blood pressure stable. And renal perfusion, we just use changes in urine volume or closely monitored. And then real-time TEE monitoring, we just monitor the cardiac function and volume change. So after the surgery, our patient, we can comparing TEE, this is after and this is before treatment, shows that we can see after treatment, the movement of the free wall of the right ventricle was significantly improved in the four-chamber view and the right ventricular inflow-outflow tract view. We can see the comparing video. This is after and this is before. And this is just a right ventricular inflow and outflow tract view, after and before. So ECG monitoring results also showed the changes of heart rate, blood pressure, and CVP before and after treatment. It demonstrated our effective treatment. Then this is the result of ECG, lower limb vein ultrasound, and ultrasonic ECG detected 2 hours after the operation, and nothing is, abnormal. And this is the change of lactic acid 3 hours after operation and the second day after operation. It showed that the level of lactic acid decreased, which indicating a good tissue perfusion and a good outcome of this patient. So this is 9 a.m. The next day after the operation, the patient was extubated and his cardiac rhythm recovered to normal sinus rhythm. And the patient is really quickly out of the ICU to the normal ward and discharged really quickly. And the outcome is really good. Then summary. Point of care ultrasound screening is very useful to quickly access patients who are encountered acute onset events, which may potentially life-threatening. Then ultrasound screening may extend our clinical perception to a higher level, especially for our, anesthesiologist. Then just like this picture show, this guy was puzzling. Okay, I'm sorry to say all your visceral, organ are missing. Then the patient just reply, okay, you may be rubbing my pillow. Then apparently the ultrasound operator placed the probe to the wrong place. This picture can tell us correctly using perioperative ultrasound screening requires training, knowledge, and responsiveness. Then that's all. Thanks for your listening.
Okay, thank you, Dr. Du. Very nice piece. You through the two cases to tell us the usefulness of ultrasound in the seriously ill patient. Now let's open our discussion and some comment. Dr. Dai and Dr. Zhuo, it's your turn, please.
Dr. Dai first.
Okay, thanks, Dr. Mi and Dr. Zhe. It's very interesting talk. Actually, we also use the ultrasound very widely in the operation, and Dr. Du showed us two very interesting cases. I'm very curious about the first case. It's very interesting. From Dr. Du's presentation, we found that it's a normal the anatomy of inferior vena cava. It's a very simple surgery, but leading massive hemorrhage. So my question for Dr. Du is that before you use the ultrasound, what's your consideration for the patients? The blood pressure has decreased, the HR has increased greatly. At that time, what's your consideration? What's happened for this patient?
Okay, thank you for your question. And at the beginning, actually, we were really confused because this patient should not have hypotension. The patient was in really good health before operation and really healthy. And in addition, the effect of routine fluid infusion and vessel constrictor drug is getting worse. Actually, even if the patient changed the position from gallbladder position to the supine position, but if the for temporarily blood pressure drop, we give some fluid infusion or some vessel constrictor drug, maybe can getting better. But this patient is really opposite. Just the action is is getting worse. And at the end of the operation, so there was no bleeding fluid in the aspiratory bottle. Actually, it's really clear. And as the patient was only a simple cholecystectomy, they even put the tube, and then the gallbladder bed and the surgical side, or the surgeon just carefully checked before they, closed the skin. And there was no bleeding and no, any bleeding evidence. Also, there was no, they didn't, actually, as I said, they didn't put the tube in and place the tube. And then, so the patient doesn't have any sign of bleeding. So we will consider using ultrasound to help us to detect it and help us to diagnose what happened in the, abdomen. So, yes.
But you have not any positive observation for the abdomen ultrasound. Do you have any positive observation?
Yes. Evidence, right? positive evidence, right? Yes. Okay. Just because of we don't know what happened in this patient, so we just use the ultrasound to help us to detective and diagnosis, I think. Then when this patient's ultrasound has proved us that with important cardiac function and volume status, they just in the four chamber view, and then have just show and the short axis of left ventricle, they just show that the cardiac function is really good, but the volume is really hypovolemia. Then the lesson learned, actually, I just say, I didn't, actually, I should trained by the, really totally, ultrasound training, but not. I just studied when I studied in Huaxi Hospital, I just studied the cardiac, ultrasound, and I studied the hepatic, hepatorenal ultrasound by myself. So, the lesson learned, I did not involve pelvic ultrasound in my ultrasound screening. So then, even if the cardiac ultrasound tells us that the patient, in under some, hypovolemia, but I still didn't check the pelvic, area. If at that time I check the pelvic area, I can find the blood and the bleeding clot there. So, and I think this just can teach us that it is necessary to master the whole technology of ultrasound. This is really useful to have others to rescue the patient. Thank you.
Okay, the second short question. I'm very curious, why do you let the patient took the angiography after surgery? What's your consideration at that time?
Yes, actually, this is a really, strange, actually a little bit special patient, because, at the end of the operation, there was no bleeding fluid as in aspiratory bottle. I just said that. And then, the bleeding area just in umbilical cord area, just then we just, there is no, actually, in normal patient, there is no such thick vein in the umbilical region of the normal patient. So since the patient has an unusual thick vein in the umbilical region, so we have performed inferior Vena Cava angiography to avoid maybe this patient have other other unknown disease. We just wanted to avoid other abnormalities in the patient and avoid miss some other diagnosis. So we just check this patient. So that's why.
Thanks.
Okay, any question from Dr. Luo?
Yes. Thank you, Professor Du, for your excellent presentation. For the first case, it's a health patient. They do normal surgery, laparoscopic cholecystectomy. And you and your team do very good ultrasound, especially TTE and TEE. But for this case, in my opinion, is after surgery, the blood pressure dropped, heart rate increased a lot. That means hypovolemia. So, I mean, surgeon should before they close the skin, they should check before they take out the trach. They should check the internal abdominal wall to make sure no hemorrhage. I think it is quite important. My question is, after surgery, how many blood volume lost? I mean, how many blood volume loss in the abdominal cavity after the surgery? Do you estimate this?
Yes, I think I consider about this, why this patient have this kind of situation for, so many times, because at that time I just studied from, Huaxi Hospital, and then I just began to use the, this ultrasound. And I think this patient, because the patient is in, actually the patient, after the surgery, they just close the, skin and suture the skin. They still on the, gallbladder position, the head is top and the foot is down. Then I think his head is high and his foot very low. Then the inferior, Vena Cava, have some pressure about, the pressure of inferior Vena Cava is not really high to bleeding. So due to the influence of body position, so it may not be easy to find bleeding at this position. And then actually the patient blood pressure is job. Actually we just turn the patient position to the supine position, then happen some heart rate increase, and then blood pressure are low, then just begin to happen. Then I think just because the position is changed, actually at the beginning the position has changed. I think the surgery just has done in the afternoon, and I think maybe this patient have no enough fluid infusion. I just thought about that. So I just give the patient fluid infusion rapidly, and but the effective is not really good. So I just give intermittent to give the phenylephrine. Actually, even if the patient do the surgery at the afternoon, but I think if as just like the normal patient, if we give all those treatment, the patient's vital maybe become much better. But this patient is become worse. So that's why at the first time I just called Blue and called our medical team to help us. So that's why. So at that time I just consider why this patient happen this hemodynamic and unstable. I just confused too, because this patient even don't put the tube into the abdomen, so no bleeding evidence, and the aspirator bottle has just no more than 10 milliliter blood, so nothing just to prove that this patient is bleeding. So I confused too. So that's why I just asked the team, our medical team, and I just used the ultrasound to check what happened in this patient. I hope I can answer your question well.
Thank you.
Okay, I think it's time to close the discussion for the second speech. Many thanks again to Dr. Du, and many thanks to Dr. and Dr. Dai for your question. So we'll go to the third speech. Please, Dr. Yu.
Last speaker was Professor Ce Lu from Peking Union Medical College Hospital. The topic of her speech was ski doctors for 2022 Winter Olympics, an anesthesiologist's point of view. Because Professor Ce Lu is not online, please play the video. We will not be able to participate in the discussion. After playing, please two experts' comments. Play the video.
Good afternoon, everyone. My name is Lu, and I'm an attending anesthesiologist, currently working at Peking Union Medical College Hospital. It is a great honor to be part of the Beyond Expo 2022 and share my experience as ski doctors providing medical service during the 2022 Beijing Winter Olympics and Paralympic Games. I graduated from Peking Union College, Medical College, and chose a career as anesthesiologist in the year 2014. And skiing was a hobby of mine when I was in college. And little did I know that this hobby will lead me to a once-in-a-lifetime opportunity to be part of international world-class winter sports events. And the Beijing 2022 Winter Olympic Games is the 24th Olympic Winter Games. It has been rated as a great success, and especially during the difficult time of the coronavirus pandemic. The Beijing Winter Olympic Games began on February the 4th with a very memorable opening ceremony at National Stadium in Beijing. The game came to an end at National Stadium after over 2 weeks of competitions. In a total of 109 events, 15 disciplines over 7 sports in 3 competition zones of Yanqing, Beijing, and Zhangjiakou. Yanqing is where I worked as a volunteer ski doctor. And China, as a host, has won a record 15 medals in total, including 9 golds, and ranked 3rd on the medal table, which makes history. The Yanqing competition zone was built from scratch for the purpose of hosting the Winter Olympic Games. The newly built Yanqing National Alpine Skiing Center is among the world's most challenging racecourse, and as evaluated by International Ski Federation, also known as FIS. Situated in the Haituo mountain area in the northwest Yanqing, the starting point of the skiing center has a maximum steepness of 68 degrees. It is one of the steepest racetracks in the world. And on top of the racetrack is a kite-like shape structure, which tops off at the highest altitude in Beijing. The skiing center has a total of 7 ski slopes, each stretching for about 10 kilometers, with a largest vertical drop reaching 900 meters, with world-class skiing infrastructure such as gondola, lift, chairs. And this picture is taken by myself and showed a part of the race course known as Haituo Bowl. And racers would race down the icy course and make sharp turns while maintaining a speed over 100 kilometers per hour. And from this picture, you can tell how steep the course is. And the right line alongside both sides of the course are safety nets, known as A nets and B nets. They're built to buffer the impact of the fall of the racer. Once the racer lost balance during high-speed skiing, the momentum of crash is similar to a motorcycle vehicle accident. This would make medical protection rather tough. Therefore, safety guarantee measure is very important for alpine skiing, and ski doctors are an essential part of the safety system for these international sports events. And alpine skiing is one of the most physically demanding sports in Winter Olympic Games. It is known as the jewel in the crown of the Winter Games. And alpine skiing is also one of the oldest events of Winter Olympic Games. At the Olympic Games, alpine skiing include men's and women's downhill, super G, giant slalom, alpine combined, respectively, and mixed team events. So there are a total of 11 events in the alpine competition at the game, with a total of 33 medals up for grabs. So it is one of the most important games during the entire Winter Olympic Games. And racers, they regularly reach speeds can be up to 140 kilometers per hour. And at the same time, racers have to navigate a winding course that contains sharp turns and sometimes soaring jumps. with speed and passion comes the risk of injury, and the injury rate in international world-class events is around 30%. So to protect the racers, a group of ski doctors specialized in skiing and medical cares has to be put alongside the racing course to provide on-site medical service no matter where the racer fall. And because injury can vary from a minor muscle torn to a very serious spinal injury or even cardiac arrest, a medical rescue needs to be carried out against time. And alpine skiing is not China's traditional strength. So the 2022 Winter Olympics is also the first international alpine skiing events that China has ever hosted. Domestic or local Chinese ski doctors are not available. So a team of ski doctors needs to be recruited from the start and trained from the start. So during January 2018, Beijing Winter Olympics Organizing Committee recruited more than 300 doctors with basic skiing skills to participate in training and selection process. And after several rounds of selection, a total of 37 doctors, including more than 10 women, joined the team and became the China's first generation ski doctor. The team are to provide medical service at Yanqing Alpine Skiing Center to athletes participating in Beijing's 2022 Winter Olympic Games. And three key elements are needed in order to become a ski doctor. The first one is, of course, an excellent skiing ability, because it is necessary to ensure that you can reach the injured racers quickly with equipment, even if injured racer is on a very steep and icy racing course. The second is you have to be able to provide excellent on-site first aid, because we may have to provide basic life support, perform endotracheal intubation, and stop bleeding, and provide intravenous medication to the injured racers on the slope. And the third key element is you have to be able to communicate in English fluent, because the racers are from all over the world, and you have to be able to communicate with them and to work with other international staff members at the Yanqing competition zone. And our team members come from different medical backgrounds, including neurosurgery, thoracic surgery, trauma orthopedic surgery, emergency medicine, and anesthesia, as myself. And although we're rather experienced in our own specialty, the team members need to receive extra training to become a qualified ski doctor. So since the year 2018, when the team was first established, we were trained extensively for a total of around 150 days at ski center at Yanqing and Zhangjiakou during winter time. The goal is to improve ski doctor skiing skills. And being excellent recreational skier is different from being qualified as ski doctor, because the latter would require you to navigating through very icy terrain, which is different from ski center, ski resort that most of recreational skiers would experience. The icy terrain while carrying a very heavy equipment and stops at any location that is needed. While getting close to the injured racer, you need to get off your ski and carry the equipment on the racing course, which is often very icy, and make assessment and transfer the racer well without falling yourself or lose one of your equipment alongside the course. There is no shortcut to skiing skills. and accept hard work. So we practiced skiing almost every winter before the 2022 winter Beijing Winter Olympic Games. And during the summer, we would receive training of international trauma life support and practice rescue protocol according to different types of injury scenario that could happen on the race course. The ultimate goal is to evaluate and assess injuries, provide on-site treatment, and transfer the injured racer from the racetrack within 15 minutes. The 15 minutes bar is set by International Ski Federation. Within 15 minutes, if deemed necessary, airway security, spine security, injured limb immobility, and anesthesia have to be performed. All team members received qualification to provide international trauma life support. And during the 4 winter high-intensity training, injuries are somehow inevitable. There are 15 serious injury incidents among the team members, and 5 of us received surgical treatment. Injuries include knee ligament tear, femoral head fracture, lumbar fracture, clavicle fracture, various sorts of contusion, concussion, and frostbite. But no one quit the team, and everyone want to ensure a world-class medical service will be provided by Chinese ski doctors at the 2022 Winter Olympic Games. We also built from scratch a medical kit especially designed to provide medical care alongside the racing course on the slope. And ski doctors must carry this medical kit, which weighed around 10 to 15 kilograms during the competition, as to offer first aid to the injured racer as quickly as possible. Inside this medical kit, we can have basic sterile patches, bandages, medical gloves, resuscitation airway mask, splints to secure the injured fractured limb, and pelvic belt for pelvic fracture, sterile wound dressing for open bleeding wounds, triangular bandage, scissors to cut off the tracking suit of the athlete, and tourniquet to stop bleeding temporarily. And also we have IV catheters to administer medications, and also laryngeal scope, endotracheal tube, and laryngeal mask airway are equipped to provide basic life support if deemed necessary. Also, a giant oxygen tank is also included in the bag. And also we have a manual suction device because on the course we don't have electrical power, and if suction is needed to remove blood or other things that is blocking the airway, we can do so by using this manual suction device. And helicopter long rope rescue is another challenge for ski doctors because some tracks are too steep for rescue boats or toboggan to reach, and the injured racer can only be transferred by a helicopter long rope rescue. Therefore, during the official competition, the helicopter needs to be ready to start at any time and cooperate with the ski doctor on the racetrack to quickly transfer the injured, because we have no previous experience to provide this kind of medical rescue. So the helicopter long rope rescue we practiced many times before the official competition. And in addition to the high demands of skiing, the cold weather is a great challenge for ski doctors, especially for female doctors. And during the game, the average temperature in Yanqing is below -10 degrees. and there is a very strong wind. When hit with winds, the body temperature can reach more than minus 30 degrees below zero. The cold weather would actually slow up your mind, slow up your movement, and the 10-kilogram bag is getting heavier, and some equipment is also failing in extreme cold weather. And to this end, ski doctors practiced ability for field rescue. And for ski doctors, observing racers' injury process can play an important role in our preliminary assessment. To see with our own eyes the impact of the fall and which body part took the hit is very important. The initial 4 minutes are very crucial for rescue. So on the field, we should keep an eye on every racer like a high-speed camera. And we have to see them racing in front of us and tracking their every movement. In case of accident, we must rush to the athlete at the earliest and accurately find out the injured body parts and transfer the racer to medical station. Therefore, being vigilant during the entire race is very important, which is very hard to do in the cold. And from the starting point to the finishing line, we have up to 9 teams of ski doctors, also known as field of play, abbreviated as FOP, alongside the course. And we would each of FOP station would communicate over the radio, because in the mountain other communication device would not work properly. For example, the FOP1 would be placed at the starting line, and alongside the course, there will be another 8 FOP station, and the last FOP station will be located near the finishing line. When a racer begins his or her race, the FOP1 at the starting point would report on the radio, racer on course, and when the racer ski past each FOP station, there will be a report in the radio as racer past FOP1, racer past FOP2, racer past FOP3. In case a racer fell, the FOP station in charge of the course where the racer fall would report on the radio. Racer fall on FOP 9, and the other team would know how what's going on and how they would react. This is a short video clip of one of the fall of these during the this 2022 Winter Olympic Games. And on February the 7th, U.S. Alpine skier Nina O'Brien slipped near the finishing line during the giant slalom event. Just to be clear, this video is not the real crash that Nina sustained, because the real video would cause some discomfort among viewers. So I changed the video to a more gentle fall. Once Nina fall, our FOP team located at the finish line report in the radio, racer down near the finishing line. And our team members rushed to Nina after received instruction in the radio. And our team provided detailed examination and emergency treatment such as analgesia. And she was carried off the course on a toboggan and sent to a hospital, where she was diagnosed with a compound fracture of the left leg and underwent surgery within an hour. After Nina recovered from the surgery, the U.S. ski and snowboard team posted a message on Twitter, said that Nina would like to express her gratitude to all of the people who assisted her so quickly in the finish area at the race, and especially to the doctors and nurses at the hospital who had taken such great care of her. And I'm very glad to know that after this injury, Nina recovered very well and would very much likely to be participating in the future alpine skiing events. And the performance of Chinese ski doctors was rated as top class by the Medical Expert Committee of International Ski Federation. And this picture picture on the right showed a handwritten note from Hans Spring, who is the official from the Medical Expert Committee of International Ski Federation. And Yanqing and the whole alpine skiing medical care work went very smoothly during both Olympic and Paralympic Games. And in addition to Nina O'Brien, more than 20 other racers have been injured. Ski doctors set out decisively and offered treatment timely, accurately, and efficiently, which presented on-site treatment of textbook level of several times, and which we are very proud. During the games, we are very likely to be joined by international ski doctors and international snow patrollers from all over the world, and formed very good international relationship. And when foreign ski doctors, when they first came to China before the opening of the Olympic Games, they had some doubts because there were no professional ski doctors in China before. And there are doubts about whether we are able to provide world-class medical service during the alpine skiing events, which is very high demanding for medical service. And after communication and working together, they have seen that our professional skiing and medical rescuing ability are very strong. And in the end, they are very pleased and happy to work with us. And the world-class Yanqing Alpine Skiing Center, the infrastructure of the Yanqing venue also made a very strong impression, which also made me very proud. And although I was separated from family members and friends during the entire Olympic and Paralympic Games, which lasted around 3 months, and I also missed spending the Chinese Lunar New Year with family, I am very proud to be involved in the game, and especially to be involved as a volunteer. The International Olympic Committee president wrote a letter to Beijing 2022 volunteer after the Winter Game, in which he stated that you can take great pride in the fact that when Beijing made history as the first city in the world to host both a summer and winter edition of the Olympic Games, you were an essential part in writing this great chapter in the Olympic history. Your genuine affection and passion for Olympic Games that all of you displayed was truly heartwarming. The athletes felt this, all of us in the Olympic community felt this, and we are forever grateful to you. Just like athletes, you demonstrated that we can only go faster, we can only aim higher, and we can only become stronger if we stand together in solidarity. And this is very motivational for me. And Beijing 2022 is aiming to engage 300 million people with winter sports, accelerating the growth of China's winter sports industry and boosting tourism in Yanqing and Zhangjiakou competition zone. And in the 2020 to 2021 winter season, the number of people engaged with ice and snow sports across China reached 230 million, which is a very magnificent number. On April the 8th, 2022, Chinese President Xi delivers a speech at a gathering to honor those who have made outstanding contributions to Beijing 2022 Winter Olympic Games and Beijing 2022 Paralympic Winter Games, which is held at the Great Hall of the People in Beijing, capital of China, as is shown in this picture. President Xi said that reviewing the 7-year extraordinary process of preparation and hosting the game, we have harvested not only the joy of success, but also abundant intellectual wealth and valuable experience, which are worth cherishing and carrying forward. I believe that achievements are made from hard work, and victory does not come easily. And the Beijing 2022 has provided me with a once in a lifetime opportunity to learn from the world's best athletes and to cooperate professionally with international ski doctors. And this experience also deepens my love for skiing, my professional identity as a doctor, as an anesthesiologist, and also my love for my country. And this experience also truly embodies the motto, the spirit for together for a shared future. And that's all. Thank you for listening.
Thank you, Professor Telu gave us a wonderful speech. Let us see beautiful Winter Olympics, but also realize the responsibility of anesthesiologists. Let's welcome Professor Dai, Professor Zuo, short comments.
Okay, I go first. Thank you, Professor Telu, for your wonderful speech and interesting story. As a sky doctor, you participated in the medical service work of the 2022 Beijing Winter Olympic Games on behalf of the Beijing anesthesiologist and shared her feelings and experience, which seemed to make us personally experience and bring us back to the Beijing Winter Olympic Games. Skiing is very interesting because it's very fast and easy to get caught in the sport. In my opinion, anesthesiologists will play a more important role in the medical services of the Winter Olympic Games, in particularly teamwork, sports injuries, trauma first aid, and cardiopulmonary resuscitation. Thank you, Telu, again for your contribution and sharing. Thank you. That's my comment.
Okay. Anyway, I would like to thank Dr. Che's contribution and sharing the precious experience with a volunteer skiing doctor during the Winter Olympic Games, including her hard training, the service in the very extreme weather during the period Olympic Games. I think she has shown the traits of an anesthesiologist, including compassion, fortitude, responsibility, and rapidness. I also highly impressed with her top talents in skiing and highly appreciate Dr. Che's contribution for our anesthesiologists. I remember several years ago, there's an Australian anesthesiologist who is also a diamond amateur and played a critical role to save the small soccer players trapped in the cave in Thailand. Anyway, I think we need more anesthesiologists like Dr. Che and actively participate in the public activity. This is a wonderful way to gain more reputation and influence for our anesthesiologists. Thanks, Chelu, and thanks Dr. Mi and Dr. Is moderating. Thank you.
Thank you. Thank you. Professor Huang Yiguang, give comments.
You see, I think the moderator for this session, Dr. Li Weidong and Dr. Yu Weifeng, you are supposed to give the summary for this session before I give some words to today's meeting.
Okay. Before Professor Huang Yuguang, the president of CIC, to give us some comments to today's meeting, I would like to make a brief summary for this session. Thank you for participating in 2022 Beyond Expo Anesthesia and Life Science webinar. The schedule is by now all over with a big success. In the fourth session, we have three speakers. They have made a wonderful speech on the advancement of both basic research and clinical practice of anesthesia. They also shared with us the improvement in anesthesia quality control and outstanding performance by anesthesiologists in major national events. I believe we all have a lot to gain and absorb. It's believed that there will be more advancement in the field of anesthesia in the next 10 years, and may all of you be part of this contribution. Thank you again for being with us in 2022 Beyond Expo Anesthesia and the Life Science webinar. Here, have a good weekend. Now let's welcome Professor Huang to give us a short speech, please.
Okay, Richard, may I just speak several words? So turn to you, okay? So ladies and gentlemen, and it's a great day today for the Chinese Society of Anesthesiology to join the Beyond Explore 2022. It's definitely successful, and on behalf of the Chinese Medical Association. So before closing, I would like to say thank you so much. Firstly, thank you, organizing committee of the Beyond Explore 2022, for your kind invitation to the Chinese Society of Anesthesiology to join you for such a great academic event. So if possible, we try to continue our collaboration and support to the Beyond Explore year later or continues for long term. Secondly, I would like to say thank you, Chinese Medical Association. But among the 91 specialty societies, anesthesia, the Chinese Society of Anesthesiology, just the first, the society among the 91 specialty societies under the leadership of the Chinese Medical Association to join such, great academic conference. So I'm really proud of our great team today because we have no time to prepare so well. We have no time to rehearsal before the meeting for presentation. Today we have 12 relatively young doctors. They just, as the keynote speaker to present their interesting topics. They are, doing great. They represent the future of the Chinese Society of Anesthesiology. No doubt about the future, because from their own, we can see the even longer for the bright future of our specialty, not only in the domestic academic the issue, but also internationally for their, go abroad to participate in any kind of international anesthesia conference or academic activities as the keynote speaker to present by themselves. I would like to thank you, the 7, include myself, okay? 7 moderators. You are doing an excellent job to make this, conference really smooth and sounds interesting, and they make our audiences feel so valuable and so fruitful after this meeting. So I think it's great teamwork anyway. So as the president of the Chinese Society of Anesthesiology, I do appreciate all your great efforts for this contribution. Without your support, I think the meeting is totally different. So once again, thank you, Richard Han, for your team to arrange such platform for this meeting today. I think without your support, we are also the different. So let's enjoy what we are doing today, but even for the tomorrow, we can strengthen our collaboration under the leadership of the Chinese Medical Association. Thank you again. I think we also appreciate our audiences on the line. They spend their precious time during the weekend, and they try to learn or share with us, although they don't, they speak by themselves, but we can hear or we can feel their great support for this meeting. So thank you for all participants and our audiences. Your support and your care is a motivator for the future and go even forward. Thank you again. I mean, together we are going to be stronger. Thank you all. Thanks. Back to the Richard Han.